Now I invite Dr. Chaitra Jayadev to present a talk on posterior segment complications of cataract surgery. To say few words.
I think we all create complications for retina people to become busy, and Chaitra is going to highlight all those cataract surgery related posterior
I'm only
segment
going to
complications.
concentrate on the posterior segment complications. The rest you'll handle.
Chaitra, very active in scientific forums, and we know that she's been part of many things, not only for South India, for entire India. Being a part of managing IGO in an earlier time, brought out so many good things. I hope that future is also brighter.
Thank you
And
so
we
much,
see
sir.
much more things in a positive manner, because academics has to be a part of any society. And sitting here, we all talk about society activities. It should have one goal to improve the academics. Therefore, I think all state society, the national society, sitting here, we should all improve the academics. And that comes with the managing complications.
Yes, sir.
So Chaitra, please.
Yes, sir. Thank you so much. Today, I'll be speaking on posterior segment complications of cataract surgery. No financial disclosures there. At the outset, I'd also like to thank KSOS for having me here. I've been visiting for the annual conference practically every year, and it's great to be back. And thanks for the panel here. I'm sure we're going to have a great meeting ahead. So cataract surgery, as we all know, is one of the most commonly performed ophthalmic procedure and one of the most successful at that. So it is quite discerning for a doctor to be aware of the different complications that can occur, because most of these patients expect to have a 6/6 vision on the first post-operative day, and especially one eye has gone really well and the next eye they come back with some complications, it's going to be rather difficult for the physician to handle. So I'm going to be covering only some of the complications. It's impossible to cover all of them. So let's look at dislocation of the lens fragments or the IOL itself, expulsive hemorrhages, choroidal detachment, retinal detachment, and cystoid macular edema. So like I said, I'm only covering the posterior segment complications. And then, of course, the most dreaded of them all, endophthalmitis. So dislocation of lens fragments can happen even to the most experienced of surgeons. The incidence is anywhere between 0.4 to 4% during phacoemulsification, and an ASCRS survey has shown it to be around 0.3%, and the UK survey has shown it to be about 1.1%. Now, what are some of the signs of a retained lens matter? It is, of course, CCC. You see edematous, hazy corneas, anterior chamber reaction, raised IOP. There's vitreous debris along with the lens material there, cystoid macular edema. And of course, the degree of inflammation is proportional to the lens fragment size that you have in the vitreous. So cortical matter typically appears white, it's fluffy, and as it gets more hydrated, it tends to become a little more fluffier. Whereas the nuclear fragments basically depends on the amount of nuclear sclerosis, the size of the fragment as well. So it's rather easy to differentiate between the two of them. So how do you handle it? Either at the time of the surgery or post-operative is what we'll see. Intraoperatively, avoid using a vectis, forceps to fish out the fragments. We see many patients coming with retinal detachment because of this. Clean up the anterior chamber of vitreous and cortex to the extent possible. Put the IOL in the sulcus if there is stability and if there is adequate support, and the suturing would be mandatory if a vitrectomy is planned next to prevent it from collapsing. So what helps us determine the time of surgery would be the redness of the patient. Sometimes they are not happy, the corneal clarity, the intraocular pressure. Sometimes we may need to bring it down if it's very high, inflammation, size of the fragment itself, and the cystoid macular edema. So if the inflammation is very minimal or it's a very small nuclear fragment, you can actually wait for some time. But if the inflammation is severe, the IOP is uncontrolled, you may need to schedule an early PPV to remove the nucleus fragment or the cortex. So this is a video which shows removal of the cortical matter. So what is important to note here is the age of the patient, the size of the nucleus fragment. Sometimes if it's really small, along with your vitrectomy, you may be also able to remove the cortical matter. But if it's a larger fragment of nucleus and there's higher nuclear sclerosis, then you would need to convert to fragmentome. Again, when you're using the frag, PVD induction is mandatory. Finish the PVD induction and then go ahead using the fragmentome. We don't have small gauge available as of now, so unfortunately we do have to convert to larger gauge. So dislocation of the IOL, quite common, either intraoperatively or postoperatively as well. You can see dislocation. We've seen patients coming with IOL dislocation literally 10 years after surgery, either because of trauma or zonular dehiscence. So many reasons are there. So when you see the IOL in the bag, some of the most common conditions are pseudoexfoliation, even a prior vitreoretinal surgery that the patient has undergone, soft silicone lenses, increased axial length, retinitis pigmentosa. And outside the bag, which means just the IOL itself, is because of PCR during surgery. So again, vitrectomy, PVD induction, and free the IOL of all the adhesions that there are. It could be quite anterior as well. So make sure all the adhesions are cleared off. And then there are different ways to remove the IOL itself. Either you fill the globe with PFCL and pick it up, or you use a forceps. Sometimes just a suction may be adequate to pull it up, and this is how you bring it out, handshake technique, and take it out from the AC. So post that, what are the management options? You either observe, you do if the patient is unwilling, you do a PPV with IOL explantation like we just saw. IOL repositioning in the sulcus, sometimes the same IOL can be put as well. If the stability, iris fixated IOLs, and then you have the scleral sutured or the scleral tuck techniques. So this is a technique that I follow. This is basically creating flanges with the suture there. A double flange is created after putting in the IOL, pass it through the eyelet there, and then create the flange. What I am using to create the flange is actually endolaser, because I have access to it. A lot of them who use cautery, but somehow I have noticed that using the endolaser is a very controlled flange is created at both ends, and I have done approximately about 100 surgeries here. It's a very easy technique, hardly any learning curve, and a lot of the procedure like you see here is done outside the globe. So, you don't really need to maneuver a lot of it, within the eye. So, that's how the flanges are created. You push back the IOL inside, make it center, and then cut the suture and make the flange again. So, this gives quite a good stable and centration as well. So what about the post-operative outcomes? Some of them do have compromised vision despite taking adequate care. This because of pre-existing ocular conditions, the corneal edema, the cystoid macular edema, retinal detachment we have seen in several of them. Now coming to expulsive and suprachoroidal hemorrhage, this is one of the most dreaded complications. It occurs when a fragile vessel is exposed to a sudden compression or decompression event. It can occur even shortly after or during the surgery, and it can occur up to 9 days as well in literature. So these are some of the risk factors. I think all of us are well aware of it. So intraoperatively, how will you identify is that there's a sudden firmness to the globe. You see loss of the red reflex, shallowing of the AC, iris prolapse, wound gape, forward displacement of the intraocular contents, and there could also be pain. So these are the different stages. You have non-appositional and central appositional. In appositional, you have with or without vitreous and retinal incarceration. So the management remains medical, surgical. Medically, you close the wound, sclerotomy only if it's necessary to close. Observe if there's no VH, vitreous or retinal incarceration, or if there's no retinal detachment. Consider systemic steroids and IOP lowering medications. Conservatively, a large part of them can be managed. But if there is sustained IOP increase, severe pain, there's oppositional suprachoroidal hemorrhage and severe persistent choroidals, or a retinal detachment, then a vitrectomy with drainage of fluid is mandatory. So secondary vitrectomy surgery may be required, and when you're doing the drainage, wait for it to liquefy, on the B scan itself. So this is the drainage. So you can see here, this is the drainage. You just have to go into the plane, and a lot of the fluid has come out. So choroidal detachment, again hypotony following surgery, wound leak, systemic steroids are more than adequate for this. And retinal detachment, again dreaded, pseudophakic RD is quite common, especially after any complications such as PC rent and vitreous loss. So these patients again have to be managed surgically. CME I will skip because I'm speaking about this in another session at 3 o'clock. I'll be covering pseudophakic CME in great detail. Lastly, endophthalmitis, it's rare, but it's a devastating condition, severe vision loss, and we can also lose the eye if it is not handled immediately. Whether it is preoperative risk factors or intraoperative, I think all of us need to be extremely vigilant about this particular condition. And these are some of the common organisms that can cause endophthalmitis. So to conclude, suspect something is amiss in the perioperative period is very, very important. And prompt diagnosis and timely management will help us save these vision in these eyes. Thank you so much.